Alright, let's talk about the cardiomyopathies. For our discussion here, there are three main groups of cardiomyopathies: dilated, hypertrophic, and restrictive. The thing to remember here is that regardless of the cause, the end result is heart muscle failure, as the name cardiomyopathy implies. We're going to start off here with the dilated cardiomyopathies. This is hands down the most common cause of cardiomyopathy, leading to about 90% of cases. Now, there are two common situations that lead to a dilated cardiomyopathy: either a disease that is intrinsic to the myocardium or a systemic disease that ends up involving the heart. The easiest way to think about dilated cardiomyopathy is that damage to the myocyte leads to decreased systolic function, and if you can't pump blood out of the chamber, then your chamber is going to get volume overloaded. This is going to cause an increase in wall tension. Due to this increased wall tension, the heart then responds by adding sarcomeres in series to increase wall thickness to alleviate the tension and allow for the volume in the chamber to increase. This process is called eccentric hypertrophy, where the chamber diameter increases as well as wall thickness increases. And this is why the hearts of dilated cardiomyopathy patients are 2 to 3 times larger than normal. And as you can see in this image, the ventricular chambers are increased in size, as well as the wall thickness has increased. Now, we ought to know the causes since this is the most common cause of cardiomyopathy. And knowing that it's the most common cardiomyopathy should help you come up with the most common cause. So what do you think it is? There you go, it's good old coronary artery disease. So coronary artery disease here can lead to acute ischemia, as seen in a myocardial infarction, or you can have chronic, long-standing ischemia. Either way you get it, ischemia leads to damaged myocytes, and this damage over time leads to impaired systolic function, resulting in a dilated cardiomyopathy. And clinically, this is why patients with newly diagnosed dilated cardiomyopathies of unknown cause, the first thing you should do is rule out coronary artery disease, and this is often done with a left heart cath to evaluate the coronary anatomy. Now, some other causes of dilated cardiomyopathy include idiopathic, or we just don't know, as well as familial. Now, while the idiopathic version of dilated cardiomyopathy is a fairly common cause, it's pretty tough to ask you questions on something that we don't really know the answer to. So let's focus on what we do know, and these would be the non-idiopathic versions of dilated cardiomyopathy, or things that we know can cause a dilated cardiomyopathy. Now, alcohol abuse as well as wet beriberi both deprive the myocytes mitochondria of thiamine. And we know thiamine is crucial for the function of pyruvate dehydrogenase to help convert pyruvate into acetyl-CoA to help us generate more ATP. So without thiamine, we wouldn't be making sufficient ATP to keep the myocytes contracting. Another point on this is that the acetaldehyde metabolite from alcohol is toxic to mitochondria. And do you remember exactly why this is? There you go, the acetaldehyde disrupts the connection of cytochrome C in the inner mitochondrial membrane. And do you happen to remember from the pathology section what this does? Well, the liberation of cytochrome C into the cytoplasm leads to activation of the capsases, and the end result here is apoptosis. So there you go. Now you know why alcohol abuse causes a dilated cardiomyopathy. Now, another cause of dilated cardiomyopathy is the Coxsackie B virus. Now, this virus invades the myocytes, and this results in an immune-mediated attack on the myocytes, resulting in their damage and therefore decreased systolic function and the dilated cardiomyopathy that we see here. And you also have Trypanosoma cruzi, which is seen in Chagas disease, and this releases a neurotoxin that directly damages the specialized conduction system within the myofibrils. Now, on top of that, cocaine, doxorubicin, as well as hemochromatosis all result in a chemical-induced toxicity to myocytes. Now, cocaine actually directly damages the mitochondrial membrane, and it can also lead to coronary artery vasospasm, inducing ischemic damage. Now, doxorubicin is an intercalating agent, and it can intercalate the mitochondrial DNA, resulting in DNA strand breaks. It also can generate free radicals, which will cause further damage, and all of this will lead to myocyte damage, which will then lead to our dilated cardiomyopathy. Now, hemochromatosis results in excessive iron deposition, and this will lead to the generation of intramyocyte reactive oxygen species, such as hydroxyl radicals. And these will go on to directly damage DNA as well as the phospholipid membranes and amino acids. Now, another cause of dilated cardiomyopathy is the peripartum cardiomyopathy, and this commonly affects women in the last months of pregnancy to several months after delivery. Now, the exact cause here is unclear, but it results in myocyte injury as well as systolic dysfunction, as you see in all the other causes of dilated cardiomyopathy. Some other potential causes of dilated cardiomyopathy include thyrotoxicosis, sarcoidosis, and Takotsubo's cardiomyopathy. Now, another name for Takotsubo cardiomyopathy is broken heart syndrome, as it's classically seen after a very stressful situation, like someone losing their loved one. Now, it will result in apical ballooning of the left ventricle, and it's due to increased sympathetic stimulation. Now, the word Takotsubo comes from the Japanese word octopus pot, which is what it resembles, and you can see an example of both of these here. Now, in this bottom image, you can see the apical ballooning. This happens during systole, and this top image here is during diastole, and everything here looks relatively normal. So with all that, what do you think you'd see on a chest x-ray in a patient with a dilated cardiomyopathy? There you go, and a large balloon-like heart, and you can see an example of this here. Now looking at this image, you can see just how massive the heart can be in a patient with a dilated cardiomyopathy. And also in this image, you can appreciate that this patient has a pacemaker, and you can see its pacemaker wires here. So if you were auscultating the heart in someone with a dilated cardiomyopathy, what might you hear? There you go, you might hear an S3 heart sound. Now S3 is due to incoming blood splashing against the large volume of blood that is already accumulated within the ventricle. And how do you think we're going to treat this patient with a dilated cardiomyopathy? Well, you can give medications to help the myocytes pump better, like digoxin. You can also give medications to decrease preload, like your ACE inhibitors. You can also decrease the symptoms of volume overload by limiting sodium and water intake, as well as giving diuretics, like furosemide. Beta blockers are also useful here, as they decrease oxygen demand, as well as decrease mortality. A few other things you can do is place an implantable cardioverter defibrillator, or an ICD, or if it gets really bad, you can set the patient up for a left ventricular assist device or a heart transplant. Now, as you move along in your training, the treatment of heart failure is something that is continually discussed. The overarching concept that you need to remember here is that medications that prolong survival are the most important and most highly tested. Alright, next up we have hypertrophic cardiomyopathy, and there are several variants here. Here, 60 to 70% of cases are due to an autosomal dominant mutation in the gene encoding sarcomeric proteins, such as myosin-binding protein C and beta-myosin heavy chain. Now in hypertrophic obstructive cardiomyopathy, patients have abnormal hearts starting at the level of the sarcomere. Here you can see haphazardly arranged myofibrils, conveniently named myofibrillary disarray. Now when this occurs, there's also an inflammatory component, which activates fibroblasts to deposit collagen in between the disarrayed myofibrils. Now all this leads to a thickened myocardial wall, as well as the heart not being able to contract correctly. Now generally speaking, when we're talking about hypertrophic cardiomyopathies, sarcomeres are added in parallel towards the center of the chamber. Now this will lead to what's called concentric hypertrophy, and concentric hypertrophy leads to diastolic dysfunction because the ventricle becomes non-compliant and does not have the ability to relax and fill with blood as it should. Now since the ventricle is non-compliant and it cannot relax as it should, it's going to take more pressure to fill the left ventricle. This increase of pressure causes blood to back up into the left atrium as well as into the lungs, and this results in our typical heart failure symptoms. Now, in a subset of patients, you can see asymmetric hypertrophy, and this is an example of this here. Now this can be of the ventricular wall, as you see in this image, or of the subaortic interventricular septum. And if it were in this particular location, why might this be bad? Well, it could create an obstruction to the opening of the left ventricular outflow tract. Also, this narrow opening creates very high flow velocities, and this can actually suck the anterior leaflet of the mitral valve over the opening, creating a sudden outflow tract obstruction. Now this sudden blockage of flow can lead to hyperperfusion to the brain, which can lead to syncope, as well as dyspnea. As most of you may have already heard by now, the story of the athlete that collapses in the middle of the game, and the underlying problem here is undiagnosed hypertrophic obstructive cardiomyopathy. Also, these patients are prone to conduction abnormalities, and these can lead to abnormal electrical depolarizations as well as ventricular arrhythmias, like ventricular fibrillation, which can lead to sudden cardiac death. Now another thing you should be on the lookout for in patients with hypertrophic obstructive cardiomyopathy is a systolic ejection murmur that increases with Valsalva. And now this is something that is very important, and it's going to show up on all levels of your exam. So just remember, systolic ejection murmur that increases with the Valsalva maneuver, and it's seen in hypertrophic obstructive cardiomyopathy. Now what should be a few other findings that you're on the lookout for in someone with hypertrophic cardiomyopathy? There you go, a huge heart. Look at the thickness of these ventricles here. So when you're auscultating the heart, what do you think you'd hear? There you go, an S4. And this sound comes from the blood when it hits the thick, stiffened left ventricle wall during diastole. Also, you can get impaired mitral valve closure because the hypertrophy disrupts normal valve alignment. Alright, now let's talk a little bit about treatment. Well, you may need to limit intense sports, as well as place the patients on beta blockers to decrease the metabolic demands of the myocardium, as well as increase the left ventricular filling time. Now, what about the non-dihydropyridine calcium channel blockers? Well, same concept here. Verapamil blocks calcium channels, and this decreases the contractility of the heart, as well as slows the heart rate. This decreased contractility by the heart leads to decreased oxygen requirements for the heart, and the slower heart rate leads to increased left ventricular filling time. Now, you can also consider placing an ICD for those who are at high risk of sudden cardiac death, such as those with previous episodes of syncope or cardiac arrest. And you could also even consider it in someone with just a strong family history of cardiac arrest with the same diagnosis. Now, I'll go ahead and say, I remember when I was hearing this for the first time, wondering, how does someone have a previous episode of cardiac arrest? Doesn't that mean you're dead? And the answer here is yes, they did die, but we were able to get them back, usually with CPR and defibrillation. So that means you can have a previous episode of cardiac arrest that you actually lived through, but it is fairly rare. Now, next up, we have the restrictive or infiltrative cardiomyopathies. Now, the name here should give you a rather strong hint of what's happening with this cardiomyopathy. Here, there's some form of infiltration into the myocardium, and this ends up restricting the heart's ability to expand and receive blood, therefore decreasing your preload. And with all that, you end up getting diastolic dysfunction due to a poorly compliant ventricle. Now, let's discuss some of the unique etiologies because these tend to be high yield. Now, first up here, we'll talk about endocardial fibroelastosis. Now here, the name tells you pretty much where the problem is. There's fibrous and excessive deposits of elastic tissue within the endocardium, as you can see here. Now, this disease usually occurs in the first 2 years of life, and this rare childhood form usually ends up requiring a heart transplant for treatment. Now, Loeffler syndrome is similar, except we have eosinophils to the equation. And here, these eosinophils are going to release major basic protein into the myocardium. Now, the major basic protein here will lead to necrosis of the myocardium, as well as fibrotic tissue deposition. And as you guess, this fibrotic tissue is not very good at expanding, so you're going to get decreased compliance, as well as diastolic dysfunction, as we saw earlier. Now, hemochromatosis is due to iron overload, and this results in reactive oxygen species forming within the mitochondria of myocytes. And these reactive oxygen species will go on to damage the myocardium, and it can result in a restrictive cardiomyopathy. Now, you might remember that we talked about hemochromatosis when we talked about dilated cardiomyopathies as well. So which do you think is more common? Hemochromatosis causing a dilated or restrictive cardiomyopathy? There you go, the dilated version is more common. And that's just because the dilated version is much more common than the restricted version. Now next up, we have amyloid as well as sarcoid, and both of these are infiltrative processes. Amyloid here results in the deposition and formation of beta-pleated sheets within the heart, while in sarcoid you get granulomatous inflammation, which can result in many different cardiac manifestations, including heart blocks as well as restrictive and dilated cardiomyopathies. And last but not least here, another cause of restrictive cardiomyopathy is post-radiation fibrosis, and this should be on your mind in any patient who receives radiotherapy for something like breast cancer. Now on to a flash quiz. What type of cardiomyopathy is associated with Friedreich's ataxia? Well, here it's going to be a hypertrophic cardiomyopathy. Remember, Friedreich's ataxia is a trinucleotide repeat disease, and the trinucleotide that repeats here is GAA. Now this trinucleotide repeat takes place within the FXN gene, and this gene is responsible for the production of frataxin, which is a mitochondrial protein. So as you'd guess, when you have the trinucleotide repeat of GAA within this FNX gene, then you can't make frataxin as you should. Frataxin is a mitochondrial protein, and it actually protects us against some of the harmful effects of iron. And this protein is found in really high quantities within the heart, brain, as well as pancreas. So without the proper functioning of this frataxin protein, there's upregulated oxidative stress caused by iron in these organs. So patients with Friedreich's ataxia will develop a cardiomyopathy as well as neurologic problems like ataxia and neuropathy, as well as diabetes from pancreatic cell destruction. Alright, just to review all that one more time, because this is all very high yield. Friedreich's ataxia is a trinucleotide repeat disease that results in the trinucleotide repeat GAA. Now this repeat takes place within the FXN gene, which is responsible for the production of frataxin. Now, since the trinucleotide repeat is here, frataxin cannot be formed correctly. And frataxin is a mitochondrial protein that actually protects us against some of the harmful effects of iron. And it's seen in high quantities within the heart, the brain, as well as the pancreas. So without this protein, you get upregulated oxidative stress from the iron within these organs. And that leads to the organ dysfunction that we see in Friedreich's ataxia, like a cardiomyopathy, ataxia, neuropathy, as well as diabetes. Alright, well that's going to wrap up the cardiomyopathies. See you in the next video.